So why artificial ventilation? There can be a lot of causes for artificial ventilation. There can be respiratory causes and non-respiratory causes. In respiratory causes, you have diseases, infection, pneumothorax, fluid in the lungs. And in the non-respiratory causes, you have cardiac diseases leading to respiratory failure. You have surgical causes where the patient has got splinting and not able to breathe. You have patients in shock who require support of respiratory system, and other injuries which are causing patient to be in altered sensorium or unconscious, leading to requirement of respiratory support or ventilation. So indications of for the ventilator. Now we have a lot of types of respiratory failure. Type 1 respiratory failure is defined as hypoxemia without hypercapnia. That means your oxygen levels are low, but your carbon dioxide levels are within the normal limit. This is the most important thing. This is basically a failure of the oxygenation. That is, there is a problem in the lung. That is why lung parenchyma, that is why the oxygenation is not adequate to meet tissue demands. So you have low oxygen but normal carbon dioxide. In type 2 respiratory failure, we have oxygen may be low, but also carbon dioxide is increased. So there is a problem in the mechanism of ventilation. It is type 2 respiratory failure is defined as buildup of carbon dioxide levels which are generated by the body, which is the body is not able to throw out. So that is why you have the retention of the carbon dioxide. So in type 2 respiratory failure, your PO2 levels are also low and your PCO2 levels will be high. What else are the physical parameters which you can easily see as a doctor or an attending nurse which require ventilation? If the patient is having a high respiratory rate, greater than 35, or a very low respiratory rate, or a patient is exhausted, he's no longer able to breathe, or he's having hypoxia, you can actually see a patient turning blue, an SpO2 of less than 90% on oxygen high support, or if you have an ABG, PO2 of less than 60, sometimes requires ventilator support. Hypercarbia is building up of carbon dioxide in the blood, which is more than 60. This often causes a decrease in consciousness levels. Purely decreasing consciousness levels where the patient is not able to maintain the airway is also a cause and reason for ventilation. If the patient is a patient of significant chest trauma, he's not able to breathe. This also is an indication for ventilation. So the causes of respiratory type 1 failure, where we said the oxygenation was low, but the carbon dioxide was normal, would be pulmonary edema, pneumonia, restrictive lung diseases, ILD. So these are all diseases something to do with the lung parenchyma. Type 2 respiratory failure, you have COPD, acute exacerbation of bronchial asthma, myasthenia gravis, where the muscles are weak and the patient is not able to take deep breaths. So that is why the carbon dioxide is not being able to be thrown out of the body. Diaphragmatic paralysis, etc. Other reasons are for ventilation. If you have intubated a patient because of any other reason, say he's not able to maintain his airway, or post-operatively, it has been a major surgery, you don't want to extubate him, or patient is not conscious, or there is severe electrolyte imbalance which is causing cardiac arrhythmias, or even cardiac arrest, post-CPR, we may need ventilation, or respiratory arrest when the patient is, that can be drug-induced, or primary respiratory arrest. So what are the materials? Now you have understood the reason why do you require a ventilator. Now what are the materials which you require when you start thinking about putting the patient on a mechanical ventilator? First, you have to think about your oxygen supply. Is it going to be through the oxygen cylinder or through gas pipeline centralized? So that has to be kept ready and checked. Then you will require for the ventilator power source. You will require a ventilator with modes which you are familiar with, and you will require equipment to manage the airway. It can be an endotracheal tube, an LMA, or even a tracheostomy tube. So first we have had the oxygen, the power source, the ventilator, and the airway. Next, you have to test whether you have now you have seen the things required for intubation or for securing airway. Now you have to think of how do you connect this airway to your ventilator. So you have circuits, you have humidifiers, you have a test lamp to see whether the ventilator is ventilating properly. So all these are the connections between the ventilator and the patient.